Welcome to the Maternal Wealth Podcast, a space for all things related to maternal health, pregnancy, birth, and beyond. I'm your host, Stephanie Theriault. I'm a labor and delivery nurse and a mother to 3 beautiful boys. Each week, we dive into inspiring stories and expert insights to remind us of the power that you hold in childbirth and motherhood. We are here to explore the joys, the challenges, and the complexities of maternal health. Every mother's journey is unique, and every story deserves to be told. Please note that this podcast is for entertainment purposes only. It is not intended to replace professional medical advice, diagnosis, or treatment. Always consult with your healthcare provider for medical guidance tailored to your specific needs. Are you ready? Let's get into it. Welcome to the Maternal Wealth Podcast. Today we're going to do something a little different. My sister and I are going to do a book review. The book we've chosen is called Invisible Labor: The Untold Story of the Cesarean Section by Rachel Somerstein. The reason why we decided to choose this book in particular for my sister's experience with her labor and delivery. She had an unplanned C-section after a long labor, and a lot of what Rachel Somerstein speaks about in her book, we found true to be of her experience. My sister Rachel is a librarian and very versed with holding book clubs. Full disclosure, I started this book and I found it very hard to get through. Many of her examples, many of her stories brought up old suppressed memories of my patients over the past 8 years. We'll get into all of that, but for now, let's welcome Rachel.
Thank you so much, Stephanie. I'm really excited to be talking about this book. I think it's something different than what I normally get to do with my work, getting to read a nonfiction book that has to do with a lot of personal experiences. It was definitely a difficult read for me as well, but also very interesting to be able to get some information that I didn't know about, considering this was a surgery that I had experienced. To get started, the book is Invisible Labor: The Untold Story of the Cesarean Section by Rachel Somerstein. Just a little bit about the author. Rachel is from the New York area. She is a writer, editor, and researcher, and a tenured associate professor of journalism at SUNY New Paltz. She holds a PhD from Syracuse University's Newhouse School and an MFA in creative writing from NYU and a BA in English and history from Cornell University. So she is definitely someone who is very academic, very smart, knows how to do proper research and find credible information. A lot of her other works include writing for the Boston Globe, The Guardian, Women's Health, and Wired. In addition to when she published this book, she was also interviewed by NPR, The Nation magazine, a lot of other publications. Were very interested in hearing her story about why she wrote this book. A lot of really great interviews. So if you wanted to learn more about her, there's a lot of information online about her reasons for writing this book. It also was published by HarperCollins, and it came out in 2024. So it's a very recent book. Definitely a lot of current and relevant information. The reason why she decided to write this book is because she herself had an unplanned C-section, which she discusses in the first part of the book. And she goes into a lot of detail about her reasons for why her experience was so visceral that she was compelled to write this book. And one of the unfortunate experiences that she had with the C-section is that the anesthesia did not work for her, which does unfortunately happen. I'm sure this is something that Stephanie will discuss at some point, but unfortunately that is something that does happen. I've heard it from other people that you can go into the delivery room and you unfortunately feel it. During her C-section, it was so painful for her because the anesthesia didn't work. she was in agony and kicking so much that nurses had to hold her down, which is a very frightening experience related to birth trauma.
Rachel speaks of feeling it when a provider says you're going to feel tugging, pressure. What the author of this book felt was the incision. And she specifically said, I felt layer by layer by layer being cut. It wasn't that she had the proper anesthetic and she was uncomfortable with the pressure. She felt herself being cut into while the OB team and anesthesia team was fully aware of what was happening.
So is this something that you've heard of happening to other patients before, Stephanie?
Unfortunately, yes. And I've seen it happen.
Okay. I know you've also discussed sometimes with emergency C-sections, if there is not a anesthesiologist on staff, sometimes they'll have to use other forms of pain medication that aren't the equivalent of an anesthetic as well.
There's a term in the labor and delivery world called lidocaine cesarean. In the event that there is not an anesthesiologist in-house at the moment that you need an operative delivery, the OB will present to the patient, do you want to proceed with a lidocaine assisted delivery, which is an operative delivery without spinal, without epidural, without general anesthesia, or possibly lose your baby's life. And that situation is presented to patients who are delivering in hospitals that choose not to staff 24/7 anesthesiologists in-house. Other events where you could see something like that happening, which was probably similar to the case and with the author of this book, where the patient needs an operative delivery, there's fetal distress, fetal bradycardia, the heart rate is down, and the epidural came out or the spinal is not working correctly or in time and the baby needs to come out. In that situation, the team could consider moving on with a surgery. The patient feels the incision until the anesthesiologist is able to put the patient under general anesthesia.
So typically there is a plan for some kind of pain relief with situations like that, where unfortunately it doesn't sound like that was a situation that this author went through. Okay. Thank you for explaining that. And it sounds like when situations like that happen, that can definitely lead to birth trauma, unfortunately.
Yeah, I mean, in a situation like that, birth trauma doesn't even do it justice. In what other form of medicine are people being cut open without proper anesthesia? It's trauma. It's traumatic. And it's very unfortunate, but it happens.
One time you gave an example of you can't ever imagine someone going through heart surgery without any anesthesia or any kind of pain relief. So why would something like this, a surgery that they wouldn't get the same kind of pain relief for it?
Yeah, absolutely.
I was just saying, this is considered breakthrough pain, right?
When I think of breakthrough pain, it's when a patient has an epidural and there might be one spot that they're feeling pain. This would be that the operative anesthetic, which is either an epidural or a spinal, is not working. It wasn't placed correctly, or it dislodged, or something happened in which there's no pain medication and the patient is being operated on. The lidocaine that I mentioned earlier, lidocaine is a topical anesthetic in which most people can relate to dental procedures, or if you're getting sutures in the ER, it's topical. So it's not a suitable anesthetic for major abdominal surgery.
Mm-hmm. Yeah, that absolutely makes sense, especially when there's a chance of something like that where someone can eventually feel it.
Yeah, absolutely. And one point that I would make is if you're having a planned surgery, a planned cesarean, talk to your team ahead of time. There's two types of anesthetics that generally happen for C-sections. It's an epidural or a spinal. And a spinal is fast acting, but the duration is shorter. And there have been many times that I have seen in my career where the team decides to do a spinal as opposed to an epidural, which is long acting. It continues on until we take out the epidural. So the team has decided to do a spinal and the surgery takes longer than intended. The patient starts to have pain and then the patient is put under general anesthesia. So that's another thing, unfortunately, I've seen many times in my career, which could have been avoided if they had just simply went with an epidural in the first place.
Talking with various medical providers, depending on who you want to be in your first birthing experience or a second one, if you decide to have more children, that is something that Rachel discusses in part of her book, when part of the solutions, finding a team of midwives and doulas and OBs and people who are very versed in these kind of situations, especially if you've been through a trauma like this before. Make sure you do the research and get that information that you need, because depending on where you're going to be delivering, you can have a difficult experience or a repeat experience, which is a lot of people are trying to avoid.
Yes, trying to avoid. Absolutely. I think that's a great point. And there are resources. Earlier, I had interviewed an old colleague of mine, Mitsusi Green, and she is a C-section doula. So she will go with moms who are having planned C-sections to advocate for them and to help them in their specific need. So there are resources out there if that is something that you might be interested in.
Yes. Yeah. Definitely something that you don't have to go through alone. Speaking of unfortunate situations with people who had to go through C-sections without pain relief, Rachel does spend a good portion of the book discussing the origins of the C-section, the history of how it came about. She was looking into texts all the way back to the 1500s and trying to find more information about the equivalent of medical professionals back in those days. She discusses maternal mortality, women who tried to give birth, complications back in those days. Women's cervixes didn't dilate. They used different ways to try to save the baby. Basically, they would learn that the mother was going to pass away and they were trying to save the baby. This led to a lot of experimentation in different parts of the world to try and figure out how they can create a procedure to remove the child, but also save the mother at the same time. It wasn't really until the 1800s when they were trying to conduct more procedures within the medical universities to create C-sections that weren't fatal to the mother. She does also discuss, which comes up very often in the rest of her book, about eventually when these procedures were brought over to America, a lot of these procedures and experimentations done by physicians were done on slaves. There was a lot of interest with slaveholders to make sure that the women they owned survived their surgeries. As we know, unfortunately, the slaveholders were trying to keep the people to work on their estates. And so they would often hire these physicians to come and perform experimentations to learn more about C-sections. So there's a huge history where the physicians did learn, but unfortunately at the expense of Black women. This exploitation also continues today. Fortunately, the maternal mortality rates are very high with Black women.
There is a memorial, I think in Alabama. Have you seen it?
I don't think I have.
A woman, an artist, let me see. She made this memorial dedicated to the women who were kept as slaves and studied upon to research a cesarean section along with other gynecological surgeries. And that was all done without operative anesthetic.
And there's been a long history, even past this, with medical experiments being put upon Black communities for a really long time. We owe so much medical advancements to it, but at the same time, it was at such a sacrifice and detriment to them. And it's things that they're experiencing today. And it's terrible. And it's definitely things that she discusses in the book and discusses understanding the history and also trying to find ways to make the necessary changes are so important for the history of maternal health.
I agree with you 100%. It's a hard thing to talk about, but it's important to talk about it. I appreciate the author recognizes the history in this country involving the evolution of a C-section and what is currently happening to Black women in this country when they are having their children.
Mm-hmm. She discusses different ways if people are experiencing discrimination or situations when they are going through their labor and delivery. They can reach out to certain organizations to file complaints. It's definitely part of discussion as a whole where a lot of things do need to change for the better. One of the other things she also discusses is healthcare is a business. And that's another part where I'm sure you've experienced as well, where outcomes of these experiences these women go through are directly related to the financial decisions made by hospital systems. Is that something you'd like to discuss a little more?
At the end of the day, the hospital is for profit. In my experience, I wouldn't say that I have worked for birth providers who are performing C-sections to fill their own pockets. What I would say is the birth providers are employees of the hospital, and the way birth is billed, it's a lump sum. It's for a C-section or it's for delivery. Thinking about turnover, thinking about how long a patient is in a bed, there are policies in place that keep patients coming in and out, admissions and discharges. And there are specific policies in place. For instance, how long is a patient going to be in the bed laboring until a C-section is called? And those policies can fluctuate from hospital to hospital. I've seen factors like that influence C-section rates. All birth providers go into their career because they want to help people. But birth providers who work in the hospital are employees of the hospital and are bound to their policies that can have an effect on the C-section rates.
It reminds me of something she also discussed in the book about providers talking about the hospital system, especially if they were coming from a smaller office and kind of being absorbed into a larger system. One of the ways the hospital system was trying to, quote unquote, streamline their service was making the providers interchangeable. So if you had an office, you couldn't personalize it. And basically every time they were expecting a patient to come in, if they were going to meet with a different provider, they'd be getting the same service with each provider, which is something that also I experienced with my OBGYN office. They said that they wanted us all to meet the doctors and all the providers, so you would know everyone. If you went into labor, you would meet someone that you met, but that didn't end up happening. It ended up being someone I didn't even know. Say you came in with very specific needs for your labor, but you're meeting with all these different doctors. Each doctor might have a different way of handling your care. So instead of working with one doctor from beginning to the end, you would be meeting with multiple doctors who might be prescribing different things, suggesting different things. You would have different relationships with these people. Trying to have a birth team who are directly related to your care from beginning to end is a very important step going forward because they need that very particular care.
That happens a lot. If a patient chooses to go with a larger group, or if insurance and accessibility only allows for you to be with a big group of birth providers, then understand that every birth provider has specific ways in which they handle their practice, whether it's from how they were trained as residents or from their experience or personal beliefs. They're human, right? So they all vary. Absolutely, there are times when a patient will come in and have very specific wants, desires, needs, and you hire one provider. Like you said, the office is full of providers, so they hire a provider that fits those needs. But once it comes to labor and delivery, they have somebody who doesn't agree with, belittle them, or not honor what they want. And that happens all the time.
Yeah.
Unfortunately, that happens all the time.
I know, that's unfortunate. It really is.
Mm-hmm. I would like to say, if you are listening to this and you have an idea for your labor and for your birth that's low intervention, really understand the different models of care when it comes to OB care and midwifery care. Many times where patients have come into the hospital, they want the midwifery model of care, but they've hired an OB.
Mm-hmm.
Understand what the two models of care are and how that will affect your experience and possibly your outcome.
And if these options are even available at the place that you've chosen to deliver at. Where I was, there was one midwife and the rest were OBs, but the midwife wasn't part of the team that worked in delivering at the hospital that I ended up delivering at. So it's definitely very different per location.
Absolutely.
Rachel dedicates a chapter to going forward, some solutions to better care. Say you're planning on a second delivery and you wanted to try again and have a much better experience than the first time, and you want to go in with more knowledge. There's a process called VBAC. Do you want to talk a little bit about what a VBAC is?
A VBAC is a vaginal birth after a cesarean. Essentially, if you already had a cesarean and you want to try to labor, what you're going to do is a trial of labor. So you TOLAC at first, a trial of labor after a C-section. If you are successful and have a vaginal delivery after cesarean, then you have successfully VBAC. So you had a vaginal birth after a cesarean.
Mm-hmm.
Not all providers support VBACs. It varies with hospital policy, provider preference. The concern is a uterine rupture. You will find providers who support a VBAC after one C-section, after two C-sections. You can find providers who will support a TOLAC in the hospital setting and in the birth center setting and in the home.
Even with home births, this is something that people would do.
Yes.
She also suggests working with trained support people. So if you haven't worked with midwives or doulas before, and that's something that you wanted to experience, especially with people who have experience with birth trauma or with your unique medical history. She also discusses encouraging parents to become more involved with the cesarean procedure if that's something that you end up experiencing as well. She discusses some options about having the parent be able to have their arms available so that they can receive the child after the child comes out, or having the drapes be clear instead of opaque so that they can see the child come out. Something else that you've also talked about, Stephanie, is trying to create a more calming atmosphere within the operating room. So with music or scents or aromatherapy, things like that, something that you can possibly discuss with the care team about creating an area of calmness, especially if it's something that you have a lot of anxiety about. Basically creating a situation of a gentle cesarean and rather than an anxiety-inducing last-minute cesarean operation, especially if you've experienced birth trauma before. But also addressing the issues that created the need for a cesarean in the first place. It seems like it's a system-wide issue, and there's a lot of different parts to it.
I was just talking about this the other day. There's this whole wave of women who have had a C-section, and the hospital uses terms failure to descent, failure to progress in labor for inductions.
Mm-hmm.
These women are coming in for inductions the labor is not resulting in a vaginal birth, and the onus is put on the woman's body when it's the system that's failing. I've been doing this for 9 years, and I can count on two hands how many times someone came into the hospital in natural labor and needed an immediate C-section.
Mm-hmm.
The C-sections are happening because the system is failing. If you are listening to this and you had an induction that resulted in a C-section, remember it has no bearing on your body's capability to have a vaginal delivery. If you went into the hospital in spontaneous natural labor and no one touched you and there was fetal distress or the labor stalled, yes, something happened physiologically with your body or the baby's body that resulted in the need for a C-section, and that's why we have them. But for these inductions that are ending up in a C-section, it is the induction that failed, not your body. I can't tell you how many times I've seen women come in toe lacking because their first delivery resulted in a C-section for failure. And I'll look at the notes and it says failure to progress in labor, and they were 1 or 2 centimeters. That's bullshit. It wasn't even in labor. It didn't say fetal distress, 1 or 2 centimeters. It's just failure to progress in labor. So I want to change the narrative. I want women to change how they feel about this C-section and take the onus off yourself, take the onus off your body, and realize it was the system and not you.
No, that's great. Yeah, it's really good for people to keep in mind going into this, and because it's something that Rachel also discusses about how after her experience, she definitely internalized how she ended up getting a C-section and blaming herself. And it was very difficult for her to come to terms with and to even eventually consider having a child again in the future, which she eventually does. But it is something where you feel like you're the failure. You did something wrong. There's only so much you have control over the situation. And a lot of times it's forces outside your control that guide the direction the labor ends up in. And that's a hard thing to accept when it's something that's so personal.
If someone goes into labor naturally and something happens and there's fetal distress, labor isn't progressing, a woman is not dilating, and then a C-section is used as an intervention to save the mom and the baby, that's amazing. That's what it's there for. But so many women are going into the hospital for an induction, and it's the augmentation, it's the Pitocin pushing the PIP. Then the patient sees sudden decrease in the fetal heart rate. You run back to the OR and it's, oh my God, thank you for saving me, my baby. When we have to take a step back and think about what caused the deceleration of the fetal heart rate. Was it the intervention or was it the labor?
And it can be so different for each person.
Yeah, it can be different, and it depends on how the provider puts it. It depends on how the nurse puts it. But at the end of the day, like I said earlier, there's policies in place in the hospital to keep things moving. And part of that movement is the induction, is the augmentation, and it can cause distress. And then if there is distress, then you have a C-section.
Mm-hmm.
The patient goes to recovery, the bed is cleaned, and a new patient will come in.
Yeah. And they have to deal with the long road to recovery afterwards, which is a whole other experience.
Mm-hmm.
And some of the things that I didn't know about, later learned about, was how difficult it can be to recover. It can take months or sometimes years, depending on the procedure, that it can affect your milk supply after you have your child. It's definitely something that I think with this book, if you are pregnant or thinking about getting pregnant, even if you can only get through it for a certain amount, or like you did, it's definitely a book that I think is good especially for people who've had a cesarean and maybe want to understand the many reasons why their birth unfolded the way that they did,
And like I said earlier, it was a very difficult book for me to read because I know as a labor and delivery nurse, I know there are other nurses who feel the same way, and we also hold that trauma. When the providers leave, who's at the bedside holding the patient's hand when they're crying, holding their baby when they're crying, giving them the medicine because the pain isn't going away, and fighting to get more pain medicine and upping the pain medicine. When all the providers leave, it's the nurses who are still at your bedside caring for you. And we definitely always have those patients that we remember. A lot of what the author was speaking towards brought back a lot of suppressed memories, which is why I had to just stop, because it was too hard for me. I know what she's talking about, and I see it all the time.
Yeah.
Which is one of the reasons why I've started this podcast. This is a safe space for women to share their stories and learn about the experience of going into labor, whether it's at home, in a birth center, in the hospital. We can learn from each other, as opposed to top down from the providers telling us this is what to expect, this is what is normal, and this is how you should feel. So the podcast really is, and has been, and continues to be, a safe space for us to collectively learn in sisterhood and create a safer, healthy, healing place for women who have gone through labor, birth, and motherhood.
Yeah, absolutely. I think to end the podcast on a positive note, getting this information out there, all these different ways, through podcasts and through books like these and through social media, people are sharing their stories and getting the word out there. We're not insular anymore. This is information we need to know. By getting this information out there, it's definitely driving a much needed change that people are expecting better when they're going into this. They know now that they have a voice and they can say no, and they can ask for better care, because they deserve better care. And I think it really helps getting this information out there so they know that they have choices.
Healthy mom, healthy baby is now the subpar. We want healthy mom, healthy baby, but we want a safe, healing, empowering experience, which is what birth should be.
Mm-hmm.
It's an experience that we truly transcend into a new person.
Mm-hmm.
And we all deserve that.
Absolutely. Part of the reason why Rachel wrote this book, to get this word out there. There's a lot of other people's birth stories, a lot of their experiences, a lot of different organizations that are really driving for positive change. If this is information that you wanted to know more about, whether you've had a cesarean or you're worried that you're going to have a cesarean, you want more information, I think this is an excellent book.
And I would add on to that, if you are in the hospital and a doctor is recommending a cesarean delivery and operative delivery, ask questions. Ask, how is this going to affect future pregnancies? Am I at a higher risk of complications in future pregnancies? How is this going to affect my breastfeeding? How is this going to affect my recovery, my mental health? What kind of therapies am I going to need after? Pelvic floor therapy, cesarean scar therapy. How is this going to affect my overall health and physical mobility going forward? You have to ask all these questions and hold them accountable for answers. Am I going to be able to drive? Am I going to be able to get back to exercising? Like, how is this going to change?
But sexual health as well.
Yes. How is this going to affect my sexual health going forward?
Mm-hmm.
Absolutely.
Even though you get the quote unquote, the okay to have sex, and that's one thing, it's from with your partner, but how is it going to affect you and your future with that as well too? So,
yeah. Especially if you've been laboring and then go back for a C-section. It's a double whammy. So when you think of intercourse, you have to think of insertion, and then you have to think of your abdomen. It's two separate things that can cause discomfort in your sexual health going forward. So those are two different things that you have to consider. It's so important to a healthy frame of mind, a healthy relationship. All of those things are so important. It's not just, yes, you want to have means to save yourself and save the baby, but when it's absolutely necessary, not just when it's convenient.
Mm-hmm. No, I think those are a lot of really good things to keep in mind. Thank you for that list. That's a lot of good things for people to know about going forward.
I know you said the book was hard for you to read. How was it for you with what you went through? We have an earlier episode where Rachel shares her story, but you can give a quick synopsis of what happened and how reading this book affected you.
Sure. The rundown was that I was induced. It took a long time. They let me labor for a while. It took 3 days before I finally got to the point where they were expecting me to be able to labor on my own. I was at 8.5 centimeters, but the doctor that I was working with at that time of that shift kept saying that I had stalled out at 8.5 centimeters and left me in a lot of pain for a long time. The epidural wasn't working anymore because I had been experiencing that discomfort for a long time. They had me do a C-section. It wasn't an emergency C-section. It was just at the point where I was too exhausted to be able to labor at that point. So I did have a C-section and I had issues and complications with that afterwards. Reading this book, it answered a lot of questions for me that I didn't even know I had, like my milk supply not being so great after having the C-section, and also some of the physical discomfort that lasted for a long time afterwards that I wasn't sure came from my C-section or from being in labor for so long. It was very difficult reading through people experiencing the same things I did and a lot of the medical stuff. I'm not a medical person, so that was very difficult. It was very difficult reading the history of cesareans and what people had to go through and to get to this point and the unfortunate history that came with it. That was very tough to read, but it also was great that Rachel also added in sections about organizations that are trying really hard to change the narrative and offer better maternal health for people going forward, to really drive down the numbers of cesareans. That was a main focal point, is that the numbers in the US are unfortunately very high, but it's very sporadic and in different locations where there definitely needs to be a more systemic solution going forward. It was a very interesting read. I did enjoy it. The hard parts were necessary parts, so I'm glad that I got to read through those as well. What you've covered so far with your podcast have been like birth stories, which has been great. It's been so interesting, but it's nice to be able to talk about cesareans as well too.
Mm-hmm. Absolutely. One of the midwives that I interviewed earlier made reference to patients understanding that obstetricians are surgeons and midwives are experts in natural physiological labor process, which represents why the C-section rate is so high in this country. Obstetricians kind of rule the land, so to speak.
Yeah, there's definitely a history there as well, where the tradition of giving birth, or I should say the practice of giving birth, definitely changed hands from being a very grassroots midwife, quote unquote, natural experience, to being placed in a hospital led by, hospital systems with very specific rules. She definitely delves into the history of that as well, which is very interesting to see, especially because how it affects today's world and people's choices with their maternal health and care.
Mm-hmm. Yeah.
Thank you so much for listening to our review of Invisible Labor, The Untold Story of the Cesarean Section by Rachel Somerstein. If you have any maternal health books or anything along the lines of labor, delivery, or any other books that you think that we might be interested in reading or discussing for future podcasts, please let us know. You're welcome to comment on our social media or email us at info@maternalwealth.com.
At Maternal Wealth, we aim to ensure that you have access to the best and the most appropriate care. That's why we created a maternal healthcare provider database. Maternal health providers can easily create profiles to promote their services and business, helping to increase access for those seeking their care. This is a one-of-a-kind database that offers a new and exciting way for women to search for and find maternal health providers near them and tailored to their specific needs. Profiles feature badges that highlight various services such as TOLAC-friendly practices, all-female practices, LGBTQAI+ inclusivity, language options, access to vaginal breech services, and more. Additionally, be sure to check out our Not Your Average Birth course. In this course, I discuss the variations that exist in hospital practices based on policies, staffing, and budgets, all of which can directly affect your birth experience and outcome.